to begin, I wanted to start by thank you for joining us here today. My name is Jennifer Strohecker. I serve as the Director for the Division of Integrated Healthcare and also the State Medicaid Director. The vision behind hosting these virtual Medicaid update meetings is to give our agency the opportunity to connect and collaborate closely with partnered individuals who work closely with those in Medicaid and CHIP. This is an opportunity for us to share the work that we're doing and update you on that, but also an opportunity for you to voice your concerns, current experiences, and provide us with feedback. So what we'd like to do is I'd like to start by going through some current activities that we are involved with in the division. And I have a slide deck prepared, which I will present to you. And then I'd like to take your questions after I'm done presenting. If you would like to enter your questions into the chat, we will begin collecting those now or throughout the time of the presentation. So feel free to put in the questions into the chat. And just to orient you to where the chat is, it's in the bottom right-hand side of the screen, and it's a little call out box. So if there is a question that you have, we would love to take your questions. I am joined by several members of the team who will be assisting me in answering your questions. So we look forward to walking through this material with you today, and then receiving any questions that you may have about the material that's presented or other questions that you have for us. So with that, I'll go ahead and begin the formal presentation of the slides. I have several areas I'd like to go through today. The first question, item I'll review is some updates regarding our new PRISM system. I'd like to then walk through some slides around Medicaid unwinding, review statewide provider training that is beginning this month, and then just outline some updated policy that is coming for the January timeframe. So as we begin, I'd like to first start with walking through PRISM and some updates that we have to share with you regarding our PRISM system. So first and foremost, as a background, in April 2023, Utah Medicaid did replace our 40-year-old claims system with a new system called Provider Reimbursement Information System for Medicaid, also known as PRISM for short. This really does support our overall functions of our Medicaid program. Overall, Medicaid processes approximately 6 million claims plus encounters annually. And this accounts for about $5 million in expenditures that also supports our providers and our accountable care organizations. We have about 65,000 actively enrolled Medicaid providers with our program. So as you know, the PRISM system then supports kind of the bulk of work that does run our Medicaid operations. As we look from the April timeframe until present, what we wanted to do with you today is go through some updates on system functioning and also some areas of focus. The first piece we wanted to focus on was our system processing, to give an update on by-month update on the claims that have processed through the system, as well as our capitations, as well as the payments tied to it. So you'll see through the month of April, May, and June, we've had millions of claims processed through the system, and correspondingly millions and hundreds of millions of dollars of payments run out through the system. So we see initially in April a higher volume of payments run through. We did have a backlog due to our system freeze that had happened in March. So we knew when we began processing claims that we had asked providers to hold claims, and then our system froze for 3 weeks. So we saw initially as claims started processing through our new PRISM system that there was a large increase in April, followed by May and June, lower volumes than what we originally saw with regard to dollar amounts running through the system. Moving on to the next slide, some of the things that we've also wanted to share with you is regarding the impact on operations. We understand that implementing our PRISM system was an enormous lift on our team side, but also on your side as the provider. We wanted to reflect some of the work that our team has done as a result of our go live with our PRISM system, and also how we've supported you as providers. Our call center with our Medicaid operations team has taken approximately 10,000 calls per month on average since we went live with Prism. This is a significant increase to our call volume prior to our Prism launch. So our team is certainly working and very busy fielding calls and taking them from our provider call center. We do note that there is about a 40% abandonment rate. Certainly, we know that some providers are holding for a period of time and don't have the opportunity to sit on hold. And so we see that some providers are hanging up and abandoning at about a 40% abandonment rate. We do have an average wait time of 28 minutes for calls. So wanted to let you know we do have a fully staffed team who is managing these phone calls. We're working through these calls and also looking at ways to optimize these calls, but wanted to give you insight into the call volumes that are coming into our call center and how that's impacting our operations. Next, we also know that there was a transition in our new system from what was a paper-driven prior authorization process to a paperless system where providers could submit paper claim or submit electronically their prior authorization requests into our Prism system, and then actually be able to track and update and follow the review of that prior auth as well as the disposition of that through approval. Our team has also seen an increase in prior authorization requests that have been received post go live of our Prism system. Prior to our Prism system launching, we had about 25 to 2,600 medical PAs submitted monthly. After our go live, we've had an increase in prior authorization requests that the team has been processing. There has been a transition, of course, as our providers have learned to use our new system, and some providers have not yet transitioned to this paperless process. And as a result, our team is working some of our paper received prior authorizations while they're also managing work through the new electronically submitted system. This is actually adding a little bit more time to our team. And that, along with some defects that we have identified post go live, have contributed to a little bit of a backlog. So our prior authorization turnaround times are sitting at about 24 days right now for prior authorizations. Couple of steps that we're taking to address this prior authorization backlog that I wanted to share with you. The first is that we are asking providers who have been submitting paper claims and still submitting those through our old pathway. We are no longer going to be allowing prior authorizations to be submitted via a paper claim process after August 1st, so today. And we are only going to allow providers to submit them through the electronic online submission in order to allow our team to really focus on that process and implement our new system. So we did give providers notice and hope that there was enough lead time to transition this, but certainly at this point now, we want our providers to be submitting prior authorization requests via electronic pathway. The other piece too is that we have identified the system defect that have been creating a little bit of a lag in the prior authorization review process, and these are prioritized for correction in the next month. We've also motivated and changed our staffing model just a little bit to get caught up, and we have set some goals for this team to be able to catch up on the backlog. So moving on to the next slide, we're looking specifically now at some of the more the issues that we're dealing with on a day-to-day basis around provider payment challenges is how we've grouped these. And there's a couple areas that we'd like to focus on. That first, we'll start on the left-hand side, which we really see as a learning curve with our Medicaid providers and some of the experiences that you may have had while interacting with our Prism system and some of the things that may have created a delay in payments. The first thing that we've noticed is that because our Prism system requires the providers to be enrolled a specific way, that some providers didn't have their enrollment set up the right way to be able to even interact with the system and be able to bill claims. As a result, I think some providers were not able to interact and use the system, and our provider enrollment team, as a result, right when we launched, did experience a little bit of a backlog with regard to getting these provider enrollment modifications. So we call these modifications caught up. And we did have a little bit of a backlog getting our providers enrolled. The other piece too is that when our PRISM system went live, there were several new provider types that were built into this system that hadn't been live before. Dental hygienists and physician assistants were two different provider types that were new and went live when our PRISM system went live. This also created a lot of new provider enrollment for the team. I would like to say that as of even early June, our provider enrollment team had been completely caught up with that work and has been able to maintain provider enrollment applications and their review process within 7 days or less. So what I would encourage you now, if you have provider enrollment issues or questions, this team has been caught up. They've been fielding lots of questions and phone calls, but they have certainly been caught up in their review times. So that is a definite way that we've been able to help providers to get into our PRISM system and been able to interact with the system and do their work in the system. So thank you for your patience with that. And we're happy to continue helping you that way. Another change and a learning curve that our providers have experienced is as we transitioned out of our older system, which is our older MMIS system, and into our newer system. Our newer system does have updated billing standards and it's compliant with our latest billing requirements. Our older system allowed a lot of other claims to be billed, maybe that wasn't necessarily up at those standards and had some workarounds. As a result, when providers were submitting claims to the system that may have reflected the old system's way of processing things, there were many different types of incomplete or inaccurate claim submission that providers were experiencing. This has contributed to some of the increased phone call volume that we've seen as well, which has been seen on the provider customer service side. So certainly because of provider enrollment questions, incomplete or inaccurate claim submissions, our team has been fielding lots and lots of questions in that and providing direct training and support to Medicaid providers so that they knew how to bill the claims properly. We do have lots of online resources and tools I'll share with you at the end to help your staff and you know how to access these services so that you can learn how our system functions, but we're also happy to continue supporting you as your questions come in so that we can help you successfully bill for claims and be able to get paid for them. If you back up just one more slide, just the slide real quick. One of the things that we also wanted to know is that one of the things that we appreciate as providers have learned to interact with the system and bill in the system, we've seen that denial rates for claim submission have actually reduced over time from 46% in April to 36% in July. So that shows us that there has been the learning curve with regard to providers learning to bill the claims in accordance with our new standards. And we're happy to continue to support you in that way. Another challenge that we faced on our side is the fact that our PRISM system, being new, was programmed over time, many years of development. So as we've gone live, we've identified either system defects that maybe weren't identified in testing or certain programming that was put in place during our design session that we actually do not want to keep in place, that are interfering with some claims processing and claims payment. Our team is working on this at our side and is developing manual workarounds to address system defects or problems that interfere with claim processing and payment. And we've been able to really mobilize additional staff and teams to work these claims so that providers can get timely payment for that. Additionally, we've built up an interim interim payment pathway so that many providers who believe that they should be paid for things and we're working on either provider enrollment issues or some of the claims billing issues that we're encountering, we have issued many different interim payments to help providers during this time of our implementation. One thing that we did want to share with you is that while we have an ongoing process of identifying our different defects and problems within the system, and we've identified 1,000 or more of those at this point in time, of those that have been identified, 61% of them have been resolved, and the other remaining of them have a release assigned, so we have a fix like assigned for future release or are in process with being developed so that we can get a date for correcting those in place. So as we identify different problems or issues in the system, we are working to prioritize and do the and get those put in the system so that they can be addressed, so that we can free up some of these defects that we're seeing. So with that, we can move on to the next slide, and I'll just refer you again to the numerous provider resources that we do have regarding our PRISM system implementation. We have at the hyperlink here provider training resources, both like taped sessions as well as tools and resources that would be helpful for you. In this, we also have different email addresses and places that providers can submit questions or concerns to us if they would like us to work through problems or assist them with claims billing problems that they're experiencing. So I'm going to move to the next topic on Medicaid unwinding updates and move into some of the work we're doing around unwinding the continuous enrollment requirements from our Medicaid program that we've had during the public health emergency. So just as a quick background and bullets on this, our federal rules during the time of the public health emergency limited eligibility reviews, and we were required to keep people who became eligible for the Medicaid program continuously enrolled through the PHE. At the end of this, we were given, again, federal guidance that as of March 2023, we were allowed to begin a process called unwinding. And this unwinding process requires the state program to review every single case of our Medicaid eligible individual and review their eligibility over the next 12 months. For this, we had actually hit our highest enrollment we ever had as a Medicaid program. We had 531,723 individuals enrolled when we began our unwinding activities. What we actually did at this point is, as we laid out our strategy for doing this, what this end goal was is to review the eligibility and then determine which program the individual would be eligible for. So as we went through our reviewing our Medicaid and CHIP enrolled individuals, the goal was to see if these individuals were still eligible for Medicaid or CHIP, or if we were to transition individuals from Medicaid to a CHIP program or to another coverage option such as the federal health insurance marketplace. Now, we did take a strategic approach in doing this work, and we're able to actually determine of our overall membership. One of the things that Medicaid continued to do throughout the pandemic was that we did take the step of continuing to do eligibility reviews during that time. So we were not allowed to terminate eligibility, but we could continue doing reviews on some individuals that were being reviewed through this time. As a result of the individuals enrolled in our Medicaid program, we were able to establish a 12-month review cycle for about half of our population. The other half of our population was put into a prioritized review list based off of their likelihood to remain enrolled in the Medicaid program. So if you could move to the next slide, please. So what we did with this is we looked at individuals who we believed, based off of our data that we had, which said these individuals weren't utilizing services. Maybe our data was showing that they were over income or that they had another type of insurance. We actually prioritized those for review earlier on in the process and prioritize those later in review in the process who we believed would stay enrolled for the process. Overall, through this whole process, as I mentioned, it was required of our program to do a review on every Medicaid enrolled individual. And there's a couple terms I'd like to point out that do occur as part of our eligibility review. And some of the partnership that we had with Department of Workforce Services that does perform the eligibility review process is that every member is required to go through a process of ex parte. And the definition of ex parte is a process that allows renewal of eligibility without the individual completing a form or providing documentation. So when the eligibility worker actually looks at a member's eligibility through the ex parte process, we're able to look at information that's already available to the eligibility agency, DWS, and determine whether or not that individual continues to be eligible. If so, we can automatically approve their eligibility without having to send them any paperwork or have them doing any different work on their part. And this is certainly an optimal pathway to review eligibility and get people to continue to be enrolled. Now, we're not allowed to discontinue anyone's eligibility through this process, but as individuals move through the ex parte process, and we're doing the ex parte reviews, there is a trigger at a certain point in the month, or if a person is not eligible through the ex parte process, where a pre-populated form is sent to the member. At this point, the member reviews would receive the pre-populated eligibility form in the mail or electronically, and have the opportunity to fill out this form to have their eligibility considered. And the reason we send the pre-populated form is because we don't have enough information to do the complete review through ex parte. Another definition I'd like to call out at the beginning of this is that procedural closures occur when there is a closure of an individual who has received one of the pre-populated forms, and perhaps this closure refers to the termination of an individual's Medicaid or CHIP coverage due to administrative reasons or procedural issues such as missing paperwork or failure to comply with certain program requirements. So if a person receives the form in the mail and they don't respond to that form or don't maybe respond to the request for information, there is a closure that can occur on that member's eligibility case because of a procedural reason. So moving into our process then for our unwinding activities. On the next slide, we wanted to give you a status update of what's been happening in our unwinding activities. I mentioned that we kicked off our unwinding in March of 2023, and those eligibility reviews occurred through the month of March, and then the closures occur actually at the end of June. So the information that's presented here is our closure notices that have occurred through those eligibility reviews through June of 2023. So through this period of time, we know that a total of 179,000 individuals have been reviewed. Of these individuals, and when this data was pulled, 81,000 individuals were renewed during this time frame, and 98,000 individuals were closed. Now, we have an asterisk here because this is a snapshot in time. And when an individual, even if their case is closed, they have 90 days to fill out that form and apply to Medicaid and actually get their Medicaid enrollment reinstated back to their closure date, so that there was actually no interruption in their Medicaid eligibility. And so we know that there is that those closures that do go out, and then people do fill out their forms and are reviewed, and then they are able to remain eligible. We see that about 30% of closed cases have later been reinstated. So there is what's called churn. We see about a 30% churn rate of individuals who did receive a closure notice, but they then did get their Medicaid reinstated. I'd like to talk just briefly about the chart on the right-hand side in this stacked bar graph that's here, because it does give a snapshot of our overall activity of the 179,000 individuals that have been reviewed, to show you the number of individuals and the percent of that population that was renewed through ex parte, which is represented in the blue box down below. Those that were renewed by filling out the form and submitting it to us, and then those in the green box that were closed for procedural reasons. As I move forward into the upcoming slides, looking at our strategies, I think this will be relevant as you look at opportunities that we have to reduce the procedural closures that we see and improve the number of reviews that are done through the ex parte process, which is one of the strategies that we're employing to help improve some of the outcomes that we're seeing through our enrollment, our process right now. So moving to the next slide, we also wanted to give you a snapshot of the call center metrics that are being experienced through the Department of Workforce Services. As we know, this is the largest project ever undertaken by a Medicaid program to review all of their eligibility within 1 year and determine the disposition of individuals and transition them successfully to other programs or keep them on our Medicaid program. We know that this call volumes are very high, and we have seen increases through the month of June. These are June numbers that are represented here, that DWS has gotten over 100,000 calls in that month alone. We also wanted to represent the call wait time of a 36-minute average call wait time during this period of time, and represent that over time, as you see in the green bar graph, that you have month by month representation. June being the very far right bar graph is that call wait time over time has remained relatively stable. Even though our unwinding has occurred, we see a small increase in April, May, and June. However, it's been largely stable over time. We know that our call center is busier. We also know that the wait time has gone up a little bit because of unwinding, because of the increased amount of work and certainly activity that this staff has had to maintain the work that and take the number of calls that have had. For this, we've had a call abandonment rate of 26%. So moving into the next and last slide on unwinding, I wanted to talk to you and share with you some of our strategies that we're employing to have some process improvements in the activities around our unwinding. So the first and foremost is that we're taking advantage of some opportunities given by CMS to further improve our ex parte process through automation. So what we know right now is that while we do have this ex parte process in place, it is fully manual. So the eligibility caseworker has to do this work manually. We know there are ways to automate this process so that the caseworker really doesn't even have to touch some of our low-hanging fruit cases. These are cases that have all of the data available electronically, and that the system itself can be able to review the case and make a determination on eligibility just by being able to automatically review that. It is our goal to put some automation in place for this ex parte process in early fall. And what we expect to see as a result of that is increase in the number of cases that are being able to review through ex parte, which will hopefully subsequently reduce the number of procedural closures that we're seeing. Another area of concern that has certainly come to our attention in an even greater way through our unwinding process is our eligibility notices. This has been an area of work that we've been running stakeholder work groups on for a period of time, where we've been looking at eligibility notices that members receive and their understandability as well as their readability. And there's been some work done in this area, but we know that there is still significant room for improvement. We are going to continue to conduct this work and actually make this work more robust and highlight the work that has been done in these work groups to really focus on these areas of confusion where our eligibility notices have opportunities. When the member gets these calls or gets these notices in the mail or electronically, they're more able to interpret them and understand the action steps that are needed in order to act on those notices that they receive. And that is something we are putting in place this month, a full project plan and charter, more comprehensive plan around that. Another step we're taking that's kicking off this week is taking a deep dive into the procedural termination data. As I mentioned, that green box that had that rate of procedural terminations did have about a 46-7% of procedural terminations. We want to do a deep dive into this and better understand why this is the outcome that we're seeing. Now, first, I did mention early on that our strategy was to review individuals who are less likely to remain enrolled in the Medicaid program early on. So we did expect to have a higher closure rate early on in our unwinding process, simply because we targeted that group. And that may be one of the reasons that we're seeing higher procedural terminations. But there's other factors we want to look at as well and make sure that we can address the reasons that we are getting a procedural termination rate that's this high. And we certainly are working on evaluating that, analyzing it, and then building in some steps to address this where applicable. Last and not least, there are additional flexibilities that CMS has put forth around engaging stakeholders to really assist us in partnership with the eligibility process and facilitation of eligibility reviews, as well as some of the application process. And we are working with CMS to get approval on that and engaging with our ACO partners to help assist with some of that stakeholder engagement. And certainly our stakeholder partnership has been a critical piece of our unwinding activities over the last year through preparation. And certainly as we've transitioned into the go live of this, they're essential, folks in the community who are doing this work. For you as Medicaid providers, as stakeholders, we're going to encourage your help with us as members are working through this and maybe unaware of what they need to do. We have lots of resources available on our Unwinding tab that have been designed specifically to be used in provider offices and in medical offices, as well as they are, direct spaces where Medicaid members may be, so that they know to update their address, complete their review when they get it in the mail, and to be aware of what's required on behalf of the members so that they can stay enrolled in Medicaid or transition successfully to another Medicaid program. So with that, those are some updates on our Unwinding activities. We do have some links available on the next slide that we'd like to share with you. We'll put those in the chat so you have those. But moving on to some quick policy updates that I would like to share with you. First and foremost, next slide talks just briefly about statewide provider training. We are offering statewide provider training this year in a webinar format, and it does kick off this month. So you'll see it kicks off. It runs from August through September. We are hosting a variety of trainings covering specific topics. Some of these are detailed in this slide as well as the next slide as we have this calendar available. This calendar, by the way, is also available on our website, and we'll make sure you have those links. But I wanted to just make you aware of these dates and the different topics that we have and how they can be of help with you. If you are interested in attending any one of these provider trainings, please register for them. We have a Google form posted on our website, and we'll put the link into the chat so that you can log into that and have that link accessible, and then go ahead and sign up for one of those and participate. We really appreciate these are designed by the staff here at the Medicaid program and the CHIP program for you. And so certainly we really value your participation in that. Moving on to some January policy updates, just wanted to highlight a couple areas we're working on with regard to some programs and some things that came through this past year's legislative session. So during the 2023 legislative session, SB 217, Children's Health Coverage Amendments, authorized the department to create a new category of eligibility for our CHIP program. And we're calling this program the State CHIP program. This program was specifically designed for children who are not U.S. citizens who may now be eligible to receive CHIP benefits. Now, you have to meet certain income requirements. They're 200% of the FPL must be under the age of 19 and have the other bullets that are listed below in order to be considered eligible for this program. This program will go live on January 1st, 2024. It was designed as a 3-year pilot program, and it was given a distinct set of state funding to support it. As a result of that, because we have a limited budget, enrollment in this program will be capped when we have hit that enrollment threshold. We don't have all the answers yet, but we are designing this program, and we're really excited for this new population to have access to low cost and comprehensive coverage. The things that we're working on right now are making sure that our eligibility system and our claims payment system are ready for these program changes. We are also designing materials and resources that we are going to be putting on our CHIP website so that you as well, Medicaid providers and CHIP providers, as well as individuals who may want to apply, have all the resources they need to be able to understand the program and what's required of them to apply to the program. So we're really excited about this new benefit that's available. Another update I'd like to share with you are just some coverage changes that occur around Medicaid enrollment. 2 pieces I'd like to call out around 12 months continuous coverage. First of all, for children. This was mandated as part of the Consolidated Appropriations Act that as of January 1st, 2024, state Medicaid programs offer 12 months continuous coverage for children. We know we already do this for our CHIP program, but now we'll have a mirrored eligibility component for our children on Medicaid as well. The other piece that we're have on our planning tracking, and we're working on final CMS approval of this, is implementing a 12 months postpartum benefit on January 1st as well. So that is slated, but we are pending final CMS approval on that benefit. But that is also coming through. The last item I'd like to talk about is the non-traditional Medicaid benefit changes. So on January 1st, again, there will be changes to Utah Medicaid's non-traditional benefits. The non-traditional benefit plan will have the same benefits as the traditional benefit plan. This was directed by CMS in order to eliminate the disparity between the coverage between the non-traditional and the traditional plan. So this will affect the following Medicaid programs. It will affect parents on adult expansion Medicaid or the parent caretaker relative program. It will affect the 12-month transitional Medicaid program, the 4-month transitional Medicaid program, and the family medically needy program. These were all programs designed with a non-traditional benefit, and they'll transition to a traditional benefit. So this coverage in the traditional program will give new resources to individuals, including non-emergency medical transportation. It will also make individuals in this program eligible for early and periodic screening, diagnostic, and treatment services, or EPSDT services, for 19 and 20-year-old individuals in these programs. It also enriches the physical therapy and occupational therapy visits, so they'll increase the number of visits they're able to get in this. It also opens up services to speech services as well as audiology services for this population. So with that, I've completed my formal presentation. I really appreciate your time. We have about 22 minutes for questions. So if we could put the slide deck down, Melissa, we will go ahead and move into, you can take down the slide deck. And if the Medicaid staff wouldn't mind coming on camera, I think we'll begin first and foremost with some of the questions that were submitted to us earlier on in the, some questions were submitted to us when people got the notice. So the first question that we wanted to present is that was that coinsurance claims, it had to do with coinsurance and claims for Part A and Part B that deny for any kind of payment, most stating that there was previous payment for the dates of service. However, the previous payment that is indicated is for Medicaid room and board claims that was paid by MCD. The Medicaid coinsurance Part B claims are for therapies provided, not room and board at all. So I'd just ask the Medicaid staff who's on here to take that question and go ahead and answer that, please. So Shandy, maybe from your team.
Sure. I don't know that we have an answer for that right now. We are aware that there is a situation that needs to be reviewed. And so we have an information request that's out there to look into the coinsurance for Medicare, Medicaid, as well as the cost reporting that is associated with it. And so we're looking into that right now. It would be helpful to have a contact of who submitted that so that we can loop them back in when we have more information. But we are aware of the issue, and we do have a ticket that's in that we're looking at.
Thank you, Shandy.
Mm-hmm.
The next question, we have multiple billing issues when customer service states that customer service states is correct, but it goes against the policy our clinic has for fee-for-service Medicaid. One example is the 26 modifier being denied, needing the physician's specialty to be radiology. So Shandy, would you or someone from your team mind taking that?
Yeah, I'm not sure who wants to try to take that one to Mel or the policy folks in that case, but the system is processing. I can tell you historically that the way MMIS was built did not really account for the global billing of the reading and the taking. And there were some nuances that we had in the legacy system that required providers to bill a certain way. There could be some behavioral changes that are not being moved over to the PRISM system when the system now has the ability to look at these in a global perspective. So I don't know if the policy folks or anyone that's been reviewing this separately has any input on that one. Doesn't sound like it. I know that it's on the table, it's being looked at, and I've got some other questions from the University of Utah on this one. I don't know if that's the provider that had submitted it or if it's someone else, but it would be helpful to kind of know who's asking the questions and how we can get in contact with them so that we can loop back around. It's important that we do this research not only for ourselves in the payment adjudication, but we want to be able to communicate back to the providers.
And I do know, Shandy, that the topic is being discussed, and that we're looking at it with policy too. But that is correct. So
Thanks, Mel.
Thank you. And we'll also, if we have your contact information when you submitted a question, we'll be happy to respond via email as well. So I think we'll start at the top then, as we look through the questions that have been submitted today. And I think I can just ask the question and then a member of the team can take it. How to correct a claim online or ask a question, re the denial. So there's a question on how to correct a claim online or ask a question about the denial of the claim.
Okay, so on to correct it online, you can correct or adjust a paid claim that's gone out or has a status of RA generated. And you would go into Prism and under the claims menu, go to adjust. And then you would be able to go ahead and adjust that claim. Now, if it's a denied claim, you would just go ahead and submit a new claim. Currently, we cannot adjust a denied claim, or reprocess a denied claim. And then as far as the denial in the Prism system, we don't return for the provider. You don't see the actual edits that are posting to the claim, but once you're in the claims inquiry, you can use the filters and use the reason code, and what's the other one? You could use the reason code and the other one. There's remittance remark code. So then you get the CARC and the RARC that we would send out on the 835. We also have a link on our Medicaid website, and I'll post it here in the chat in a moment, unless you have it, Tiff, where we post out there if the CARC and RARC, and then it will give like the edit number and a brief description of the edit number, to help you understand a little bit why the claim is denying.
Yeah, I put that in the chat for you.
Yeah, I think the other thing to mention too is probably around like the e-learnings and the resources. I know that Jen had mentioned some of those earlier that are out there available on the website. So if you go out on the website to the Medicaid website and you go under Prism, you'll see that there's training resources there. And a lot of those have some e-learnings. If you haven't taken advantage of those already, that's what I would recommend. When you do that, it will actually show you the system and walk you through kind of the process for each of those types of steps. And then that way, if you have more detailed questions, as you ask the customer service reps, they can give you kind of walk through it in a little bit more detail if needed.
Thank you. Thank you, Rita. Thank you, Jason. Let's move to the next question around 835s. When will 835s be corrected completely? It is hit and miss when we receive them. Sometimes they come through electronically, and other times we have to print and manually post the remits.
So I can probably take that one. Anyone else who wants to jump in can, but just at a very high level, one of the things that we found is that providers may not have the right security profile set up to pull down the 835s. Is that correct, Tiff? We have an EDI department that can help walk through that with them, and we can enter the phone number and the options to reach them in the chat also. The 835s, from what I understand, other than pharmacy, have been corrected completely, and it may just be a matter of you having the right security profile in Prism that you can go in and pull those down. Anybody else want to add anything to that?
Yeah, a couple of things real quick. So as Shani mentioned before, there was a defect and there was a change request that we had to do to change the process for our 835s. So the way that we designed it, we wanted to change it to be work differently than we originally designed. So those pieces have been completed in there. So there was some defects that were holding up the 835s before, and some of those were only showing up where you'd have to go look at it as a PDF and have to have the right security profiles. But those have since been corrected. The pieces that are still outstanding is we're still working through our pharmacy 835s. And that piece we're working on getting resolved, but most of those should be all resolved by September. So, and then I think one other thing to mention there too is we did have this week where our 835s went out a little later because there was a delay in our processing for the payment. So those ended up going out around, I want to say like 3 o'clock yesterday, which is a little bit later than they normally do. So if it was specific to that week, to this week, that might be part of the reason for that is it was a late delivery of those.
Thank you, Jason.
Yep.
And Shandy. I think the next from Tanner Insurance is a comment that, I may have skipped one. My apologies. Our team is enrolled in Prism, which works originally, but now cannot get in. Every time we try, we get an error message that the server is down. I've made multiple calls to get help with no support. We have no other way to submit our authorization requests. So Trina, from this question, I'm wondering if it's specific to logging into the system, or if it's logging into the system, if it's a provider enrollment question, and if reaching out to the provider or enrollment team would be helpful. I don't know, Shandy, if you want to speak to this question. I haven't heard about the server being down, if that's an error message you've heard about.
Yeah, well, anyone else can also speak up to this, but I'm just kind of going by what others have put in here as answers. And so it could be that if the error message is a 404 error or the server is down, it could be a result of browser caching. What they're recommending is to clear the browser cache or use an incognito browser session to see if that resolves the access error. So I don't know if they're trying that or not, or open up another browser. You say you've tried that. Okay. Jen Mains, do you have any other thoughts to that?
That usually resolves the error. The other, we could do a session directly with them to resolve it.
With the with Trina?
Provider, yeah.
Are they having that on multiple computers? Do you know, Trina?
Yes.
Okay. I wonder if it's a firewall issue on their side too. We can look and see. So yeah, I think that would probably be the best, is to set up a separate discussion with that.
Okay. And Brian also mentioned that to clear your cookies.
Mhm.
That may have worked for them. Okay.
We did that. How do I set up a separate call to talk to somebody about this?
Will you just put your contact information and, well, let's just see.
Trina, you can email it.
Email it
to
to
us.
Jen, or the same one for the questions.
Okay. Thank you.
Thank you. Yep. Thank you. Okay, I'm going to go back to the top again and just move on to Tanner Insurance did make a comment about calls maybe being dropped, not abandoned, but that the system is actually dropping calls was their experience. Shandy, do you have a comment on that?
There's been a couple that have mentioned that in the chat. So we will look into that with our DTS folks who run our Genesis lines and see if it may be a capacity issue. I don't think so, but we've seen an exponential amount of calls come through recently. And so our phone lines are just above what we've been for years. I mean, we had a very low percentage of abandon rate and a very low wait time of less than a minute. And we are experiencing extremely high peak times where calls may be at an hour and a half. The average wait time is about 30 minutes. So it may depend on when you call. But we are aware of it, and we're doing our best to manage through it. We do have some ideas that we're troubleshooting with leadership, and I will check with DTS to find out if it is a capacity issue.
Thank you, Shandy. And thank you for your question. Okay, there are a few questions I'm seeing about this that I'd like to just talk about regarding some discrepancies that are seen between the eligibility lookup tool and then what the individual may be enrolled in. And so there's a few questions as I've looked through the chat here that are looking at that. Now I'm not seeing the specific scenario. I'm sorry, I moved around on here. But when they look in the eligibility lookup tool, they may see a plan assigned and then they don't see a plan assigned during the same time. And we want to talk about the system and what we've experienced with the eligibility lookup tool being updated. Greg, would you like to take that question, or would another individual like to talk through that specific question that individuals have posed around plan assignment and the ELT?
Yeah, hi, this is Greg Trollin. Yeah, so I would say that we're just in the process of trying to get the ELT synced up with the PRISM information. There's been some delays in some of that information updating on a consistent basis. So you may, at one point during the day, check the ELT, and it's not going to be corresponding with the information that you would look up in PRISM. We are in the process of trying to get all this information resolved right now. We've been working with the files, the eligibility enrollment information that goes out to our plans, and then also just trying to get the information synced up between the ELT and the lookup in PRISM. So I think ultimately where we've been landing is we understand that there are at times discrepancies between the information potentially that an ACO or managed healthcare plan is showing in relation to maybe what PRISM is showing with respect to enrollment with a plan. So we understand we're working through those particular issues. Where we've been trying to stress is that our PRISM system is really the source of truth. And if there's any issues on a provider side, providers should take a screenshot of that information. Again, we can also troubleshoot some specific scenarios, particularly for member-specific concerns as it has to do with potentially some issues with their enrollment with a plan or those types of things.
Thank you, Greg. I'm looking at the next question by Sylvia, looking at CMS recent proposed regulations to add intensive outpatient as a billable service to the fee schedule. That's a policy question. I don't know that I have an answer to, or there are other individuals on the call right now, but I will take this one back and get an answer out to you with regard to where we are with researching that. With regard to how many lives the new CHIP program will cover, I believe we have slated just over 1,000, like 1,200, 1,300 lives that this may be able to support annually. So Paul, you asked a question around, is there a backlog in a specific area, or has it been across all types of claims? So specifically when we look at backlog, I know I talked about a backlog with our prior authorization requests, and then a backlog, or there are some claims that have been denied. So I want to make sure we're answering your question correctly to understand if you were referring to a backlog on claims with regard to suspended or denied claims, or if you were looking at the prior authorization request. So maybe if you could clarify that, that would be helpful. If you're still on and would throw that clarification into the chat, that would be helpful for us. Prior authorizations, thank you. So specifically, I know the greatest backlog is around DME, imaging, and surgeries are the three areas, and wheelchairs that have experienced the greatest backlog. Some of our other programs are current and have been a little bit shorter turnaround time, but those are our areas of our greatest backlog and where we are targeting right now some of those interventions to bring that down. Okay, moving to the next question. I apologize, I'm scrolling up and down here. Some of my calls have been dropped. This is from Ikarini. The majority of hold time is between 45 minutes to 1.5 hours. So I apologize that your hold time has been so long. I know that this past month, certainly our call volumes have gone up even more and the call wait times have gone up, and we're sorry during some of those peak times when you may have called. I don't know, Shandy, if there's anything you want to say. We're presenting an average of overall calls, but
Yeah, I think we kind of addressed this a little bit earlier on, and I think just remember that the staff are really eager to help, and they're doing their very best. I mean, we're all just humans trying to get through these difficult times, and we're doing our best to answer those calls. There are other means of information out there for providers rather than holding. If you're not familiar with our PRISM training page on our Medicaid website, it's going to take you probably less time to get through a training than it is to hold on the call right now to reach somebody. But Emily, maybe you could just say hi, show your face, let them know who you are, and say anything you want to say about the hold times. But
Sure.
Is there anything that you can think of that might be more helpful for providers calling in? We do have peak times. Are there times of the day that maybe calls are not as high?
Well, right now I feel like we are at peak all day long. We are trying to field as many calls as we can. We're trying to get fully staffed. We're in the middle of hiring. I know that even my staff, they're also learning the PRISM system. And so, we're not 100% knowledgeable on everything. And so we're learning with you. And so we appreciate you understanding that, it may take a little bit longer to get some answers. But yeah, we know it's very busy. They are definitely trying their best, and we appreciate your patience. Looking to next week, we are, if you need help with PRISM, getting logged into PRISM, getting access to PRISM, we really want to push that, because once you're in, you can look at all of your claims and get all of your answers without waiting for us. If there's questions on a specific denial, certainly give us a call, but using those resources and getting onto PRISM will be your best bet.
Yeah, I think that's the bottom line up front, is that everything that we can see in the PRISM system, providers are able to see also.
Sure. And I just wanted to say, if you have emailed me, I'm really trying to get through my emails. With the workarounds with claims, I've been super busy. So I promise I'll get to you if I have missed anything. So thank you.
thank you. And Ekaterina, you had your hand raised. Do you want to make a comment? Okay. We are at time, and I recognize there are many questions still in the chat that we would like to answer for you. What we'd like to do is actually get your contact information and be able to respond via email to the questions that you've presented. We also want to make sure that you have our contact information so that you know how to reach us. But what we'll do is, we've recorded this meeting today. We also have documentation of all the questions that have been put in the chat. If you only have your first name in the chat and you've asked for a question that you'd like us to respond to, we would love for you to just maybe add your contact information and share it with us so that we can get back to you. We thank you so much. Wanted to just thank you for attending our session today. We are running another session next week. It will be a very similar presentation to support Medicaid providers. I want to thank you for the work that you do on behalf of the Medicaid members and CHIP members that you serve. We appreciate that your work, and appreciate your partnership in implementing our new system. And we know that it is a learning curve, and we would love to hear from you if you have suggestions, other questions, ways that we can help you, and things that we can assist with. Please reach out to us. We'd love to assist you. Thank you very much for your time today.